I'm going to talk about coronary angiography and PCI in the prior TAVR patients. When I started trying to find these coronary ostia, it felt like going on a blind date or like being blindfolded and trying to find something in a dark room or like finding a needle in a haystack. So it really takes understanding the anatomy of the aortic root, the coronary ostia, and the transcatheter valve structure to really get a good hang of what guide catheters to use and how to approach these patients. So I'll start off with this slide that shows the prevalence of CAD in these patients. It ranges between 20 to 80%. The low-risk trials that just came out, it was about 20%. And CAD is a progressive disease. We don't have a mandate about how to treat these patients pre-TAVR. Different people are treating these in a different way. So there's untreated CAD post-TAVR. The indications are expanding to younger, lower-risk patients, and so all these together we'll need more coronary angiography and PCI in the future. So there have not been any randomized trials, but there's a lot of these observational trials that show that PCI and coronary angiography with multiple valve types are feasible. And you can see most of them are almost 100% successful. And you're using a bunch of catheters, and I'll go through that. So there's factors that impact the coronary reaxis, particularly the anatomical factors and device and procedure-related factors. If you look at the anatomical factors, your STJ dimensions, the sinus height and width, the leaflet length, bulkiness, and the coronary heights. These are the important ones, anatomical factors. And the device-related factors, such as the commissural tab, where is it located? Is it in front of the ostia, or is it away from the ostia? The height of the sealing skirt, and then your implantation depth. So I'm just going to cover two most important valves that we're using in the US. I know the Lotus is just approved. The Medtronic valve, if you look, the inflow diameter at the bottom is the size of your valve. There's a waist that's narrow, and this gives some gap between the frame of the valve and your aortic root, and so you have space to engage your coronary ostia. There's an outflow diameter, which you don't really worry about because it's above the ostia. The frame height is about 45. Your commissure height is important. It's twice the skirt height, about 26, and your skirt height is about 13 millimeters. So you have to be really wary about coronary ostia height of less than 10 to 13 millimeters. So if we go closer, the height of valve implantation is really important. Normally, we implant them at 3 to 5 millimeters below our annulus. And so if it is a high implant, as you see here, and if the coronaries are low, then your skirt might just be in front of your ostia, and so you're coming in from either a diamond on the top, or just on the sides. So if the coronary ostia are less than 10 millimeters, the implant has to be at least 4 millimeters below the annulus. Now, what about the location of the commissural tab? If it's away from the ostia, it's okay, but if it ends up being in front of your coronary ostia, and then you have to come in through these diamonds on the side. The width of your sinuses is important. For narrow sinuses, where there's not enough space between the valve and your aortic root, you use smaller catheters, JL335, and for your RCA, JR4. And if it's wide, you need a catheter that has a longer peak, such as JR45 or 5 or AR2 for your right. And if you're coming from above, something straight like a multi-purpose might work. Now, there's other ways to engage, such as sending your coronary wire first, or tracking with a balloon, such as balloon tracking, and then guide extensions as well. Now, for the Sapien valve, it's a little bit more simpler. The height is much less than your core valves. And you can see that the outer skirt is, or the inner skirt is between 8 to 11.6. And these are the valve diameters. You don't have that narrow waist like you have for the Medtronic valve, but there's these 12 cells that are much wider, and then these commissural tabs that you have to be wary about. Now, the same thing with the height of implantation. Normally, we implant 80-20. Here, it's implanted just at the annulus at 0 level, and so if your coronary heights are low, less than 11, you see that the skirt falls in front of the ostium, and so you're coming from the top. In case of bicuspid valves, one favorable factor that I want to mention is having the raphe between your left coronary cusp and the right coronary cusp. This causes unequal expansion of the valve, creating space between the stent, the frame of the valve and the coronaries, and so this is much better to engage. Now this is just a great, this is from Dr. Kinney's paper, where you have a good algorithm of how to engage or what guide catheters to use. So in a Medtronic core valve, you could use a J wire or a stiff angle glide wire to get into the diamond, and then you look at the commissural post. If it's away from your coronary ostia, you can use FL3 or 3-5 guides. The second would be Icari right, 1 or 1-5. And then these are the other ways to engage that we talked about. And the right, you can use an FR4 and an Icari right. Now, with wider sinuses, like I mentioned, AR2 or multipurpose may be the way to go. So the same guides, again, you can use with if the commissure tab is in front of your ostia. But again, you have to come either from the side or from the top. And with the Edwards Sapien valve, absolutely no issues. You can use standard guide catheters. Whether the post is away, then you come coaxial, and if it's in front, then you come from the side. I'll quickly go through this case. It's an 80-year-old man who's post-TAVR. You can see that was a TAVR implantation. The left fills normally, and was having a lot of angina, and so we did a diagnostic. You can see that as I mentioned, the bulkiness and calcification of the leaflet is an important factor when you're doing PCI in these patients. So this bulky leaflet is occluding the left main. It's almost 80% occluded. So how do you wire this? You can't, we used a JL5 guide, and then you can't wire this straight. It's almost like going through a completely occluded lesion. So we used a micro catheter and had to wire it. This is that Turnpike LP with a BMW wire, and then for support, send it all the way down, and then we just, after that, the steps are pretty much the same, ballooning with an NC balloon, and then the other important thing is after stenting this, one stent, that does not provide the required radial support that we would normally get in a routine artery because of that leaflet compressing on the left main. And so we had to put in a second stent and then post-dilate again to 5/15. So this is the final IVUS, and we had a good result. So really important to understand this interaction between the valve, the root, as well as the heights of the sinus, and plan your procedure. And that was the final results. So take home, I would say, TAVR is expanding to younger, low-risk patients, and we'll be seeing more of the CAD, ACS post-TAVR. And coronary angiography and PCI is feasible, as we have seen in a lot of these observational trials. And it's important to understand this interaction between the three factors while doing your PCI. I didn't touch on this, but there's a lot of other valves, the ANA valves and the Accurate Neo that we'll probably see in future that will help access to our coronaries. And then finally, I didn't touch on this either because of time, but CT imaging can be used for planning your stable cases, though this may not be very helpful in your ACS cases. So that's it. Thank you.
Stay there.